Evening, everyone. Our seminar today to talk about the hand and wrist joint. I'll start with the hand bones. We have 27 bones arranged as carpal bone, metacarpal bone, and phalanges. Carpal bone, 8 in number, arranged in 2 rows, proximal and distal, 4 bones for each. The proximal row, named from the lateral to the medial as scaphoid bone, lunate, triquetrum, and pisiform bone. The distal row, trapezium, trapezoid, capitate, and hamate. Metacarpal bone, 5 in number, numbered from the lateral to the medial, first to the fifth, had distal head, shaft, and proximal base that articulate with the carpal bone and with each other, except for the first one, that not articulate with the second metacarpal bone that give the thumb free movement and make it less likely to be fractured. In the dorsal aspect of the base of the third metacarpal bone, we have a styloid process. Phalanges, 14 in number, distributed as 3 phalanges for each finger, except for the thumb has 2 phalanges, proximal phalanx, intermediate, and distal phalanx. The distal phalanx distended at the distal end, forming the tuft of the distal phalanx. Radiology of the carpal bones. We have PA view, lateral, oblique, and carpal tunnel view. This is the PA view, show the proximal row and distal row of carpal bones. This is oblique view and lateral view. Carpal tunnel view, taken by dorsiflexion of the wrist as much as tolerable and taken infero-superiorly centered on the anterior aspect of the wrist. The view, here we have the pisiform bone, the hook of the hamate, capitate bone, and the scaphoid bone. This space is the carpal tunnel. Radiology of the metacarpal and phalanges. This PA view also and oblique view, lateral view. Metacarpal sign. Line tangential to the head of the fifth and fourth metacarpal bone should not cross the third metacarpal bone. This is seen in 90% of normal hand. If this line crosses the third metacarpal head, this indicates positive metacarpal sign and seen in gonadal dysgenesis. Carpal angle. It's formed by line drawn in the tangential to the proximal end of the scaphoid and lunate bone crossed by line drawn tangential to the proximal end of the triquetrum and lunate. It's 138 normally. If reduced to 108, so this seen in gonadal dysgenesis. Metacarpal index. By measuring the length of the metacarpal bone from the second to the fifth and divided by their breadth at the midpoint, then the sum is divided by 4. Give normal range 5.4 to 7.9. The range of 8.4 to 9.4 is a cut-off point of abnormality and suggests arachnodactyly. Sesamoid bone. We have 2 sesamoid bones seen on the anterior aspect of the thumb metacarpal interphalangeal joint. As we see here, the sesamoid bone in the joint of metacarpal phalangeal joint of the thumb, and here in the interphalangeal joint. The incidence of sesamoid bone increased in acromegaly. Bone age. A radiograph of the left hand is used to determination of bone age according to the epiphyseal appearance and fusion. Ossification of the carpal bone. These ossify from a single center for each, except of the C4 bone. The carpal bone ossify on clockwise direction, started at the capitate 1 to 4th month, then hamate at the 4th month, triquetra at 3rd years, and lunate at 5 years, scaphoid, trapezoid, and trapezium at 6th year, and the pisiform bone at the 11th year. Ossification of the metacarpal and phalanges. These ossify between the 9th and 12th fetal week, so at birth, the epiphyseal palate is cartilaginous, so not seen by X-ray. This is the X-ray of the newborn baby. Secondary ossification center appear in the distal end of the metacarpal of the finger from the 2nd to the 5th. This is the proximal epiphyseal palate. Appear at the 2nd year of life and diffuse at 20 years. Distal. Proximal epiphyseal palate appear on each phalanx of the fingers and on the proximal end of the first metacarpal bone. Appear between 2 and 3rd year of life and diffuses between 18 and 20 years of age. This is X-ray of 15-year-old boy. Incomplete diffusion of the epiphyseal palate proximally and distally. This is X-ray of adult, show complete diffusion of epiphyseal palate. The palmar aponeurosis is a continuation of the palmaris longus muscle and associated fascia. It acts as a protection for the palmar content and send 3 deep septa, one for the 5th metacarpal, called medial septa, and the second for the 3rd metacarpal, intermediate septa, and to the 5th metacarpal, the lateral septum. We have 2 spaces in the palm. Mid-palmar space in yellow color, as you see here, is lie between medial septum and intermediate septum. It contains the flexor digital sheath and digital nerve of 3rd to the 5th digit and lumbrical of the 2nd to the 5th digit. The thenar space, seen in green color, lie between intermediate and lateral septum, contain flexor digital sheath and digital nerve for the 1st and 2nd digit and lumbrical for the 1st digit. Compartment. We have thenar compartment and hypothenar compartment. Thenar compartment lie lateral to the lateral septum and contain thenar muscle and vessels, and hypothenar compartment lie medial to the medial septum and contain hypothenar muscles. The tendon and soft tissue of anatomy of the digit. As we see in this figure, we have flexor digitorum superficialis tendon that passed and then slipped to form a sling, then attached to the proximal end of the middle phalanx of the finger. From this sling, the flexor digitorum profundus tendon passed to attach finally to the proximal end of distal phalanx on the volar aspect. On the dorsal aspect, we have the extensor tendon that attached to the proximal end of the distal phalanx. The volar palate. It represents the ligamentum thickening of the volar capsule that bridges and stabilizes the volar aspects of interphalangeal joint and metacarpophalangeal joint. The dorsal hood represents the ligamental thickening of the dorsal capsule that bridges and stabilizes the dorsal aspect of joints. From the dorsal hood, an oblique ligament called the sagittal band passes that stabilizes the extensor tendon on its central position during the extension of the metacarpophalangeal joint. Collateral ligaments stabilize the ulnar and radial border of the interphalangeal and metacarpophalangeal joint. Injuries. Collateral ligament injury, or what we call gamekeeper's thumb. It occurs when we have a fracture on the base of the proximal phalanx of the thumb due to tear of the ulnar collateral tendon. Mallet finger. This term used when the flexion deformity of the distal interphalangeal joint and results due to tendon origin or bony origin. If the extensor tendon of the finger loses its continuity to attach to the proximal end of the distal phalanx, that give us the mallet finger. Also, In case of fracture of the dorsal lip of base of the distal phalanx intra-articularly, this gives us the mallet finger. Flexor digitorum profundus injury or jersey finger. It's uncommon and occurs when avulsion of flexor digitorum profundum tendon from its insertion into the base of the distal phalanx. THENAR eminence. The THENAR eminence composed of four muscles take their name from their action in addition to word pollices which related to the thumb. We have abductor, pollicis brevis and flexor, and opponent pollicis and abductor. Hypothenar eminence. They are abductor, flexor, and opponent digiti minimi. Blood supply to the hand. The radial artery enter the wrist joint at the lateral aspect. First give a branch to the superficial palmar arch, then passes via the floor of the snuff box of the anatomical snuff box to give to the dorsal aspect of the hand, then enter between the first and second metacarpal to give a branch for the deep palmar arch. Ulnar artery is larger and more deep. At the wrist joint becomes superficial and give a branch to the deep palmar arch, then forming the superficial palmar arch which give branches to the finger. This angiography show radial artery, ulnar artery, and here the deep palmar arch. This is show the small arteries in the fingers. Venous of the upper limb. Small veins of the upper limb. Small vein unite together to form three main veins, two on the dorsal aspect, basilic vein and cephalic vein, and one in the palmar aspect is the median vein. I'll stop here and my colleague will continue.
شكرا دكتورة رغد. دكتورة محمد يكمل.
السلام عليكم أستاذ. نعم أنا راح أتكلم.
السلام ورحمة الله.
We will talk about. واضح الصوت؟
واضح محمد.
In the second part we will talk about the joint of the wrist and the hand. The wrist joint is a complex area of joints. These joints are made up of articulation of more than one bone. These are distal ulna, distal radius, and carpus. The distal radius is formed of a broad articular surface for articulation with carpal bones at the wrist, and with the distal ulna at the distal radioulnar joint. A styloid process which provides attachment for the brachioradialis muscle and the radial collateral ligament of the wrist. The articular surface of the distal radius is divided into scaphoid and lunate facets. The distal ulna is formed of a head for articulation with the carpal bones at the wrist and with the distal radius at the radioulnar joint. A styloid process which provides attachment for ulnar collateral ligament of the wrist. Wrist movements, flexion, extension, radial and ulnar deviation occurs at the radiocarpal joint. Pronation and supination occurs at the distal radioulnar joint. The distal radioulnar joint. It is a synovial pivot joint. Articular surfaces are the head of the ulna, the ulnar notch of the lower end of the radius, the upper part of the articular disc, the triangular cartilage. This articular disc is triangular with its apex attached to the styloid process of the ulna and the base to the ulnar notch of the radius. It separates inferior radioulnar and radiocarpal joints. Capsule of this joint is slightly thickened anteriorly and posteriorly. It is lax superiorly and extend upward as a pouch, the recessus sacciformis, in front of the lower part of the interosseous membrane. The radiocarpal joint. It is a synovial joint. Articular surfaces are the distal radius, distal surface of the triangular cartilage, the proximal surfaces of the scaphoid, lunate, triquetral bones. Ligaments of radiocarpal joints are palmar and dorsal radiocarpal ligaments, palmar ulnocarpal ligaments, ulnar and radial collateral ligaments. Carpometacarpal joints. The carpal bones articulate with the metacarpal bones at 5 carpometacarpal joints. The thumb carpometacarpal joint is the most mobile articulation, as it is a synovial saddle joint between the trapezium and the thumb metacarpal. The carpometacarpal joint of the medial 4 metacarpals has a single synovial cavity and is also continuous with the intermetacarpal joint of the base of these bones. Structurally, they are most close to ellipsoidal joints. However, their curvature are small, leading to a functional classification as plain synovial joints. Moving from radial to the ulnar side, the 2nd to 5th carpometacarpal joints exhibits an increasing range of movement. The 5th carpometacarpal joint is considerably mobile. Flexion and lateral rotation of this joint facilitates cupping of the palm. A metacarpal joint is found between proximal and distal rows of carpal bones. It permits flexion, extension, adduction, and abduction of the wrist. Intercarpal joint, these are synovial plane joints, are multiple intercarpal articulation. They share a common synovial cavity strengthened by multiple intercarpal ligaments. The intercarpal width should be uniform and not more than 2 mm in adults, except for the scapholunate distance, which should be less than 3 mm. The metacarpophalangeal joints are collection of condyloid synovial joints. Each metacarpophalangeal joint is formed by the convex head of the metacarpal bones, which are received by the concave bases of the proximal phalanges. These joints provide flexibility and stability of the fingers. Interphalangeal joints. These are synovial hinge joints of the condylar type that allow flexion and extension. These joints permit fine motor movements in the digits, flexion and extension. The thumb has a single interphalangeal joint. The 2nd to 5th digits each have a proximal interphalangeal joint between the proximal and the middle phalanges, and the distal interphalangeal joint between the middle and distal phalanges. Intrinsic ligaments of the wrist. These are located between the carpal bones. The most important ones are scapholunate ligament and lunotriquetral ligament. The scapholunate ligament is composed of 3 parts: the volar trapezoid-shaped, middle triangular-shaped, dorsal band-shaped, which is the strongest one. It permits gliding and torsional movement of 2 bones against each other. At the same time, the joint surfaces allow functional interaction between the proximal and distal wrist. This enables important homogeneous movement between extension and flexion, and in particular, radial and ulnar deviation. Lunotriquetral ligament. This connects lunate and triquetrum, allowing the triquetrum to be displaced from proximal to distal during ulnar deviation. It is part of the triangular fibrocartilage complex. Its stability is reinforced by interosseous fibrocartilage. Radiological assessment of the wrist joint. Plane radiograph. The normal alignment of the joints of the wrist and the hand is visible on the PA lateral oblique radiographs. Damage to any of interosseous ligaments can cause displacement of 1 or more bones. Wrist lateral view. CR is vertical to the wrist joint. The centering point is radial styloid. This position is used to demonstrate displacement in fractures. Distal radius and ulna and the proximal half of metacarpals should be demonstrated. On the lateral radiograph, the capitate, lunate, distal radius articulate with each other and should be seen lying on one on top of the other in a straight line. Distal radius and ulna should be superimposed. The pisiform is the most anterior carpal bone on a true lateral X-ray of the wrist. Wrist PA view, CR is vertical to the mid-carpal area. Distal radius and ulna and the proximal half of metacarpals should be demonstrated. No rotation. The centering point is midway between the radial and ulnar styloid. The articular surfaces of the carpal bones should be normally aligned in 3 arcs. Arc 1 describes the outer proximal convexities of the scaphoid, lunate, and the triquetrum. Arc 2 describes the distal concavities of the scaphoid, lunate, and the triquetrum. Arc 3 describes the proximal convexities of the capitate and lunate. Important radiographic anatomical features of the wrist. The ulnar variance. This refers to the anatomical variation in the lengths of the radius and ulna. On PA radiograph of the distal forearm, the radial styloid process usually extends 9 to 12 millimeter distal to the articular surface of the ulna. Variance refers to the articular surfaces of the radius and ulna at the level of radiolunate articulation and is classified into neutral ulnar variance. The articular surfaces are at the same level. Positive ulnar variance, the ulna is distal to the radius. Negative ulnar variance, the ulna is proximal to the radius. Ulnar slant of the radius. This is an angle produced by the articular surface of the distal radius on a PA radiograph. It's normally from 15 to 25 degrees. Palmar inclination. An angle of volar tilt of the articulating surface of the distal radius on a lateral radiograph. It is usually between 15 and 20 degrees. Carpal instability. The carpal ring theory has been described to explain carpal stability. The proximal row acts as intercalated segment between the distal radius and ulna and the distal carpal row. The proximal carpal row moves as a unit stabilized by interosseous ligaments, allowing controlled mobility of the carpus. In the event of a carpal fracture or interosseous ligament rupture, uncontrolled motility can occur, resulting in instability of the intercalated segment, of which are 2 main types: dorsal intercalated segment instability and volar intercalated segment instability. On the lateral wrist radiograph, the stability of the intercalated segment can be assessed by measuring the scapholunate angle, normally between 30 and 60 degrees, Capitolunate angle, normally between 0 and 30 degrees. While most of the dorsal instability is abnormal, in many cases, volar instability is a normal variant, especially if the wrist is very lax. Scapholunate angle is normally between 30 to 60 degrees, questionably abnormal if it is between 60 and 80 degrees, and it is abnormal if it is above 80 degrees. It indicates instability of the wrist. Capitolunate angle, normally it is below 30 degrees, abnormal if above 30 degrees. This also indicates the instability of the wrist. MRI of the ligaments. Scapholunate ligament at the MRI, the scapholunate ligament is delta-shaped in 75% of cases and linear in approximately 25%. It is hypointense in approximately 75% versus heterogeneous with area of isointensity in 25% of cases. It is usually less than 3 millimeter in maximal transverse diameter in the coronal plane and is interposed between the scaphoid and lunate in the axial plane as a thick dorsal for stability and volar fibers. and an interposed membranous portion. On MR imaging, following injury of the scapholunate ligament, we see a loss of the delta configuration of an intact ligament, apparent swelling or thickening of the ligament due to intra-substance edema. Following rupture, the hyperintense fluid is noted to pass freely between the radiocarpal and metacarpal joint spaces. Induced changes in the biomechanics following ligament rupture produce commonly identified radiographic signs. Widening of the scapholunate interspace more than 4 mm teratomas sign. Volar angulation and flattening of the scaphoid producing the ring sign. The distal pole of the scaphoid projected over the waist and the proximal pole. The dorsal tilt of the lunate relative to both capitate and the scaphoid, producing a dorsal intercalated segmental instability pattern. Lunotriquetral ligament. It is composed of both volar and dorsal components that attach directly to the bone, rather than to the hyaline cartilage overlying carpal bones. The ligament establishes continuity between radial and ulnar structures of proximal carpal row of bones, or intercalated segment. Identification of acute rupture requires high-resolution image, and even with meticulous attention to detail, the sensitivity of MRI in this setting is as low as 50%. The triangular fibrocartilage complex. It's a complex anatomical structure composed predominantly of a triangular wedge-shaped fibrocartilaginous disc, bridging the distal radioulnar joint. It's supported anteriorly and posteriorly by the radioulnar ligaments, distally by the attachment to the lunate through the volar ulnocarpal ligaments, laterally by the ulnar collateral ligament and the extensor carpi ulnaris. The complex is completed by an additional fold in the lateral capsule interposed between the ulnar styloid and the triquetrum, termed nuchal homologue. At MR imaging, the triangular fibrocartilage is the only structure of the triangular fibrocartilage complex consistently identified, although three-dimensional gradient echo sequences now allow visualization of both volar and dorsal radioulnar ligaments. Extensor compartment of the wrist. The anatomy of the extensor surface of the wrist is defined by the extensor retinaculum and Lester's tubercle, a dorsal tubercle of the distal radius. The extensor retinaculum is an oblique thickening of the fascia that attach to the distal radius on the radial side, and the triquetrum and pisiform on the ulnar side. Its deep attachment to the radius and ulna divide the extensor aspect of the wrist into 6 compartments, each with a single synovial sheath containing one or more tendons. Flexor retinaculum attached laterally to the scaphoid and the trapezium, and medially to the pisiform and hook of Hamate, forming the carpal tunnel that transmits the superficial and deep flexor tendons of the fingers and the thumb, except flexor carpi ulnaris and palmaris longus tendons, and the median nerve. Carpal tunnel syndrome. It results from the compression of the median nerve within the carpal tunnel. It's a cause of significant disability associated with compressive neuropathy, characterized by nocturnal ascending pain emanating from the wrist, with sensory symptoms affect the first 3 digits and radial aspect of the 4th. This is an ultrasound view of the median of the carpal tunnel syndrome. On the left, transverse ultrasound of the median nerve just proximal to the carpal tunnel inlets shows enlargement above 14 square millimeter with loss of neural fascicular structure. Increase in the nerve caliber is the most reliable ultrasound criterion of the carpal tunnel syndrome. Guyon's canal. This is a fibro-osseous tunnel that permits the passage of the ulnar nerve as well as the ulnar artery and vein. Its floor is formed by the flexor retinaculum and its roof by the palmar carpal ligament. It has a proximal radial wall formed by the pisiform and a slightly distal ulnar wall formed by the hook of the hamate. Coronal T1 weighted images the carpal canal with a slow signal flexor tendon is visualized. The linear high signal structure seen centrally is a section of the median nerve. The Guyon canal is between the hamulus of the hamate and pisiform. Tendon injury at the wrist. Extensor carpal tenosynovitis. This injury resulted from a chronic occupational overuse presented with ulnar-sided pain mimicking triangular fibrocartilage tear. MR imaging, the tendon sheath is thickened associated with peritendinous hyperintense fluid on T2 weighted sequences. In chronicity, foci of mineralization with the tendon are often noted to be hyperintense. The gradient echo coronal image reveals extensive fluid signal intensity in the arrowheads along the ulnar side of the wrist surrounding the extensor carpi ulnaris tendon, the arrow. First, extensor compartment syndrome, the Quervain tenosynovitis. Repetitive wrist flexion and extension, particularly repetitive extension of the thumb, may promote chronic tenosynovitis in the first dorsal compartment or a fibro-osseous tunnel at the level of the radial styloid, surrounding the extensor pollicis brevis and abductor pollicis longus tendons. At MR imaging, there is a focal peritendinous fluid and appearance of tissue thickening. At the MR imaging, there is a focal, as we said, peritendinous fluid and appearance of tissue thickening. Scaphoid and associated injuries. The scaphoid is the second most commonly fractured bone of the wrist, typically complicating fall on a dorsiflexed hand. And displaced fractures heal without complication in up to 95% of cases. Displaced fractures occur in up to 30% of cases. And when displacement is greater than 1 millimeter, approximately 50% of cases develop either non-union or avascular necrosis or both. Fractures are classified by site and orientation into those affecting the proximal pole, the waist, and the distal pole. Fracture of the distal pole rarely develop either non-union or avascular necrosis. In contrast, the fracture of proximal pole develop non-union in almost all cases. Healing of the fracture through the mid-zone or the waist is variable. Now for the question.
دكتورة إيمان.
نعم أستاذ. A scaphoid bone.
اوكي. أميد رحمن. B.
نعم أستاذ. lunate bone.
اوكي لوني. تمارا. C.
نعم أستاذ، هذا الستايلويد بروسيس أوف راديوس.
ستايلويد بروسيس أو راديوس. سؤدد.
أستاذ distal radioulnar joint.
اكسلنت. عندنا بقت سارة عباس الإي.
نعم أستاذ. سيسمويد بون.
اكسلنت. اوكي. يلا أستاذ محمد.
معين أستاذ علي. ياسمين. A.
نعم أستاذ. triangular fibrocartilage.
triangular fibrocartilage. زين. هدى رعد.
نعم أستاذ. البي ترابيزيوم.
زين. مروان. سي.
أستاذ الثيرد ميتاكاربال 1 بيز ماتا.
هديل.
سكافويد.
مرتضى.
نعم أستاذ. الحميت بون.